Hello, listeners. This is Dr. Lauren Burkard-Mandel. I'm a breast imaging fellow at the Roswell Park Comprehensive Cancer Center in Buffalo, New York, and a member of the training editorial board for the RSNA's Imaging Cancer Journal. This is the RSNA's Imaging Cancer podcast, and today's guest is Dr. Debra Monticciolo, emeritus faculty from Baylor Scott and White and the director of the Foundation for Imaging Research and Education. Dr. Monticciolo has served as the former president of the SBI and of the ACR, has served on the FDA's National Mammography Quality Assurance Advisory Committee, and has chaired many educational committees throughout the SBI and the ACR. This includes serving as the chair of education for the SBI. Today, she is here to discuss a recent publication in the Journal of Breast Imaging entitled Mammography Screening Should Begin at Age 40 Years. This article is a response to an inflammatory publication in the New England Journal of Medicine written by Woloshin et al., which argued that the data is not sufficient to support annual screening mammography in women beginning at age 40. Dr. Monticello, I cannot wait to discuss this important issue with you. Welcome to the podcast, and thank you for joining us.
Thank you for having me. I really appreciate it.
This publication outlines some extreme limitations in the Woloshin article. And the really striking one to me was the obvious omission of the role of breast cancer screening in declining breast cancer mortality rates. Why is this such an essential piece of the puzzle when discussing breast cancer mortality?
Well, that's a great question, and I appreciate you drawing attention to this article. Breast cancer death rates have been decreasing since mammography was introduced in the United States in the 1980s, and screening mammography has been a very important component of that decline. Now, a lot of folks also recognize that better treatment has played a role, but the results would not be achievable without early detection with screening mammography. And we can simply look to Tabar's work in Sweden, although there are certainly other scientific work supporting the idea that screening has benefits, including the randomized trials and a lot of observational studies. But Tabar did a very important study. It was published in the journal Cancer in 2018, and it covered almost 6 decades. It's a 58-year study. And every woman in his study had either 10 or 20 years of follow up. So that's an extensive amount of follow up. All of the women, both screened and unscreened, had access to the same available treatment. So as treatment advances occurred, they were given to both screened and unscreened women. So using the same available treatment, screened women had a 60% lower mortality at 10 years follow-up and a 47% lower mortality at 20 years of follow-up than unscreened women. And that tells us something very, very important, that screening really has a huge effect on overall mortality regardless of the available treatments. And that's just one article. Tabar's original article looked at one county in Sweden. Duffy and Tabar followed that up, looking at 9 counties in Sweden and expanding this to over 500,000 women. And the results were similar. So, it's really important to note that we are making progress in breast cancer with decreasing breast cancer mortality rates. But screening mammography has really played an important role in that.
Yeah, and I think the key miss in their statement is that, they attribute that a lot, as you mentioned, to the treatment, where in reality, without screening, that early detection piece would be missed. And so, I think that's really an unfair statement to say just because breast cancer rates are declining that we can stop screening. It's really
Right.
truly the opposite.
Right. And actually, it's difficult to look at US data because we don't have an organized screening program in the US. We have opportunistic screening. But if you look at the death rate in the United States, for years, breast cancer was increasing, rates were increasing, and breast cancer mortality was increasing. So the death rate was flat. And it only started to drop early 1990 and afterward because screening mammography was introduced in the late 80s. And we feel that's, a large part of the reason. And if you look at the decline in mortality up to around 2013, it's continued to decline, but the data to that point showed a drop in mortality for women of 37%. And a lot of people who are anti-screeners say, well, that's due to better treatment. Well, if that were true, then men who get the same treatments as women, but who are not screened, should have the same mortality drop. And they did not. It was actually about a positive 7% mortality rate for men, but it oscillates around 0 for men. So we didn't see the benefit in men because they're not being screened. So it's a combination of the two. So to say one can do it without the other is really misleading for women. We really do need to encourage early detection if we want to be successful in saving lives, breast cancer.
And this is a really good bridge to another really important point I think is brought up in your response regarding young women and women under 40. We're seeing dramatically rising cancer detection rates in women under 40 and even under 30. And these are women that are not part of our traditional screening population. So I'm hoping that you can speak to that a little bit and also speak to if you see those recommendations changing anytime soon.
Well, that's a very interesting and provocative question. Screening is based on the underlying prevalence of disease in a population. So, it's the reason we don't screen men, right? Men get breast cancer too, and in some ways it's more lethal in men. And stage for stage, men do worse than women in mortality rates. But, they have such a lower prevalence. It's like a 100th of what women see. And so we don't recommend overall screening. So this is problematic when we look at screening younger women. And we've always supported started screening at age 40 and no later than 40, because if you look at the data and look at the breast cancer incidence, as women in the United States age from their late 30s to early 40s, the incidence of breast cancer doubles. And then it increases again in the late 40s. So there's a sharp rise in breast cancer incidence when women enter their 40s. But there still is plenty of women in their 30s that get breast cancer. It's just as a part of as overall population, it's smaller. So fortunately, we've been steadfast in saying annual screening at 40, and we've been supported in that by a lot of different organizations, including the NCCN, for example. Now, the task force has finally come back to this. In 2002, they recommended screening starting at age 40 and accepted annual screening as a very good option. And then over the last 2 decades, they've pulled back from that and telling women to wait till they're 50. And that's been very dangerous for women. And you can look at almost any study showing how effective screening is for women in their 40s. And part of this reversal by the task force, I have to believe, is the recognition that minority women in particular get tumors at younger ages. And we've been calling this out for a long time. Our recommendations paper from the ACR for both average risk and higher risk women have pointed that out. And we've been trying to get across the idea, which is supported by data, that Black women are really a high risk group. Now, if you look at the numbers, and we did a paper published in Radiology Cancer in 2021, Ed Hendrick and I, and we looked at age and ethnicity and breast cancer incidence, advanced stage disease, and breast cancer mortality rates for different cohorts. And if you look at minority women in the US compared to non Hispanic white women, these women are getting tumors at younger ages than white women overall. So we have to recognize that. Now, we showed that using the mark of 50, that minority women are 72% more likely to get an invasive breast cancer under the age of 50 than white women. They're 58% more likely to present with advanced disease, which is much harder to treat. And they're a whopping 127% more likely to die of breast cancer under the age of 50. This type of data we hope would stimulate people like the task force to see it's really a bad idea for all women to wait till 45 or 50 to screen, but it's a disaster for women of color, particularly Black women. Now, under 50 also includes women in their 20s and 30s. And so the question is, should that be moved? Is 40 early enough, especially for Black women? I'm not sure it is. I think we really do have to push the idea of doing a risk assessment in their early 20s, at least by age 25, so that we can get women into supplemental screening or early mammography screening as appropriate if they're at higher risk. And Black women, it doesn't take much for me to prompt a Black woman to get supplemental screening because, if you have dense breasts or anything else that adds to it, your risk is just going to continue to bump up. So I think we really have to be aware that, especially the minority cohorts in the United States, are getting tumors at younger ages. Getting people in for risk assessment is important so we get them into surveillance as early as possible. And certainly, there isn't any woman in the United States that should wait until after the age of 40 to initiate screening.
And I'm very glad that you brought up this disparate, screening, but also outcome for Black women because there was a quote in that paper that really stood out to me, and I want to just read that for our listeners. It was annual screening of women ages 40 to 70 years. So this is not even talking about young women or women under 40, but 40 to 70 years with annual breast tomosynthesis averts 35% more breast cancer deaths in Black women than women of other races. So, it's really, as you said, emphasizing the importance of Black women initiating screening at 40, if not earlier. And I was hoping that we could discuss a little bit, and I think we've touched upon it, but I think we can expand upon it a little bit and just how changing screening recommendations might worsen those disparities if we were to increase that to, like we said, age 50.
Yeah, or even biennial screening, because, the problem is that younger women have more aggressive tumors. I mean, you and I both know that as breast imagers, they just move more rapidly. Black women have more triple negative disease, which also tends to have quick doubling times. So waiting 2 years to screen them is really not very beneficial. It really misses the mark on finding tumors that we can really treat effectively. So what the task force did was compare Black women to all women, and the all women category contains Black women. So it wasn't a very clean evaluation. And so in our paper in radiology, Dr. Hendrick and I and Mark Helvey looked at the CISNET modeling. And we used population data to separate out Black women from non Black women. If you look at the CISNET models, they looked at mortality reduction in different screening scenarios, comparing Black women, as I said, to all women, which is not a very clean comparison. But at every scenario, whether you're doing biennial 50 to 74 or all the way to annual 40 to 79, Black women don't have as good a mortality reduction as all women. It's close, but it's not as good. And that's just speaking to the fact that they're getting tumors at younger ages and more aggressive tumors and presenting with more advanced disease. So there are disparities, as well as disparities in access to care and treatment, even with other things being equal. So it's important that we address this. And actually, when we compared Black women to non Black women, annual screening ages 40 to 79 would avert 42% more deaths. So it is really important, that annual component, and screening. I always say we need to screen early and often, right? We want to start early and we want to keep it going. And we had to model to age 79 because that's the oldest age for which the CISNET modelers released data. But they do have, this data is based on the Breast Cancer Surveillance Consortium. And we know that women in the United States screen past the age of 79. The data is there, they just are not making it available. So I really do wish they were more transparent in that regard. But I do think we do have to address these type of disparities, and the more we focus on it, the better we'll do in just getting the word and the word out over and over.
Yeah, and I think on the note of getting the word out, one of the things that you also address in this article is the overestimation of harm. And so I was hoping, we could discuss that a little bit too, because we see patients come in with concerns for the radiation exposure and the stress of a workup. And so I think these are real things to discuss, but as your article mentions, overestimated when we compare that to death from breast cancer.
Exactly. And none of these risks of screening, which the task force calls harms, are lethal. I mean, they're just not. So, you have a mammogram, and what are the risks? One is that you're going to be recalled for a few extra images. Another is that you might be recommended for a biopsy, almost all of which is done with a needle nowadays, minimally invasive biopsy. And then there's anxiety and overdiagnosis. And the first two of those we can quantify. The last two we can't. I mean, I think anxiety is important, and especially our front line on that are the technologists. They're really good, I think, at comforting patients and paying attention to that. So I wouldn't minimize that at all, but I think it's manageable. Also, overdiagnosis is a concept. It can't be measured, but it's likely very small, especially for women in the 40 to 49-year age range. It's less than 1%, really. And then we come down to the things that the task force focuses on, like recalls and biopsies. And, what they correctly point out is the more mammograms you do, the more recalls and biopsies you're going to have. The numbers go up if you screen more. Well, yeah. And you find more cancers, and the lives saved go up too. So what we did is we looked at it from the woman's perspective, right? That's what a woman really wants to know. How is this going to affect me? If I go for a mammogram, what's the chance I'm going to be recalled? Or what's the chance I'm going to be recommended for a benign biopsy? And it turns out, using DBT with annual screening, 40 to 79, it's lowest. It's 6.5% chance, less than a 10% chance, 6.5% with annual screening starting at 40 for a recall. And for a biopsy, it's less than 1%. The number is actually 0.88, but it's 1%. But in any scenario that we looked at, recalls under 10%, the highest was The current task force recommendation of biennial 40 to 74, it's 8.5. And then biopsies is 1.25%. So really, 1% chance of getting a needle biopsy. And, again, like you said, you're comparing this to possibly again having an advanced stage of breast cancer and dying. I mean, that's not, those are apples and oranges. So I think most women, we presented this data so that women would understand, here's what you can expect. This would be your experience if you get screened in the United States. So the risks I think are reasonable, they're manageable to get the benefits.
Yeah, and I love, that number you said. If we switch to biennial screening, then that recall number goes up. And of course it does because we're seeing changes that we need to then address. So I really, it's a really wonderful point that, changing those recommendations really worsens some of the relative harms that they're discussing.
Right.
And so I think, just from a general population standpoint, but also from a fellow physician standpoint, what do you think the main takeaways are from this paper that we can relay to our patients as, obviously as breast imagers, but also as general physicians and even as lay people that might be listening or might have loved ones that are hesitant to receive mammography?
Right. Well, the main message is that breast cancer screening is extremely effective starting at age 40. There's plenty of data, and it's an important component in decreasing breast cancer death in this country. I think Wallenstein and his colleagues kind of not understand that breast cancer mortality is not trivial in this country. It's a large number of women who die every year, and decreasing it by 40% saves a lot of women's lives. So these are big numbers, and why accept half of that benefit when you can get much more benefit with annual screening than biennial and starting later. So I would say please support annual screening starting at the age of 40. It is effective for women in their 40s and beyond. Don't let anybody try to fool you into any other scenario. You'll have science on your side if you support annual screening at 40.
Love that. Science on your side. Well, this has been a wonderful discussion. I really appreciate your expertise and your dedication to how important annual screening is, especially at the, beginning at the age of 40, or as you said earlier, if the risk factors support it. So I just really appreciate taking the time to discuss this with us and, for the sake of our listeners.
Thank you for having me. It's really been a pleasure.
Thank you so much. Thank you so much for listening. Please remember to rate, review this podcast on all platforms, and we will see you next time.